Hello. Thank you for this opportunity to speak today. My name is Stephen Taylor from East Carolina University, and on behalf of my co-authors, we'd like to present our research real-time feedback devices associated with improved outcomes in cardiac arrest. We have no financial relationships or conflicts to report, and we found little research demonstrating feedback devices improve manual CPR quality or survival. The purpose of our study was to determine if real-time feedback for manual CPR improved survival for out-of-hospital cardiac arrest. Our study population or setting was a population of 190,000 and with 28 annual EMS responses. Our county, Pitt County, in eastern North Carolina in red, is about 60% urban, about 40% suburban and rural. We work with 19 volunteer fire departments, one city fire rescue department, 7 independent EMS agencies, and 1 municipal agency. This is a retrospective study with pre and post interventions with only manual CPR from 2012 to 2018. Our 2 cohorts compared ROSC, in-hospital admission, and 30-day survival with CPC 1 and 2. We also performed a secondary analysis with the ZOL-X series on CPR using the CPR stat pads and compared rate, depth, and release in the first 12 months versus the last 12 months, with the idea that our first 12 months would be a representative, probably the best representative that it could be, of our pre-intervention phase. And we looked at the AHA standards for compression rates, depth, and release. Statistics were performed at an alpha of 0.5, and our exclusion criteria were patients under 18, trauma patients, patients with DNR status, and mutual aid responses. Over the 7-year period, we had 978 arrests, 485 pre-intervention, 493 intervention, post-intervention. During that period of time, comparing our cohorts, there were no statistical differences in bystander CPR, witnessed arrests, or shockable rhythms. So in this research, in this results chart, you'll see the 978 patients, mean age about 61. Gender was about 60% male and about almost 50% Caucasian. In red are the Utstein criteria: witnessed, shockable, witnessed and shockable, CPR prior to arrest, first responder, and layperson bystander CPR. You'll note during the study period, our post-therapy group actually had from 4 to 6.6% decline in these categories. Of statistical significance in this chart was ROSC, and it improved 13.8%. So that's 27.4 to 41.2%. Further results outlined here, lined in purple and outlined in red, are the statistical significant results. Good neuro outcomes for all rhythms, CPC 1 and 2 increased 5.1%. Good neuro outcomes, shockable rhythms, CPC 1 and 2 improved 14.1%. And good neurological outcomes, not witnessed, not shockable, improved 6.5%. Of note, Utstein criteria with witnessed and shockable and bystander CPR had an improvement of 12.8 and 16.3%. But due to the limited amount of patients that fell into those categories, we did not have enough patients to rise to the statistical significance there. Looking at our endpoint results, out-of-hospital cardiac arrest rate, in-hospital admission rate, 30-day survival rate, CPC 1, 2, all statistically significant, odds ratio 1.8 to 2.4. And you can see in our ROSC rate, it came from 27.4 to 41.2, 8.9 to 15.2, and survival 8.2% with CPC 1 and 2 to 13.4%. Sub-analysis are CPR deltas and our compression rates. This chart, the white is above target zone, blue is below, and the orange there in the middle is actually the in target zone. We started out going a little too fast, so we started out with 38.3% in target zone, and the last 12 months we had improved that to 55.3%. Statistically significant, odds 2.0, a confidence interval 1.98 to 2.02. Sub-analysis of our CPR depth change was 28.5, again, following that orange line. White is above, blue is below. 28.5 in our first 12 months to our last 12 months, 33.9. Again, significant result. Odds ratio 1.29, confidence interval 1.27, 1.3. And our last CPR metric, our release velocity, when we started, 192.9 and our last year was 399. Keeping in mind that 400 milliseconds, and that's what these are all representative of, 400 milliseconds is the AHA standard. This graph here depicts our entire cohort for all the years. Purple is percent. The yellow is actual count. The red line are total CPR survivor, total cardiac arrest survivors. So you'll see the red line rises above the yellow line. That takes into account the CPC 3s and 4s. In Canada, the Transport Accident Commission put out a campaign: if you drive distracted, you're driving blind. Don't drive blind. In CPR, don't be distracted and don't perform CPR blind. Use feedback devices. Use your metrics, depth, rate, and release. So in conclusion, our study suggests that utilization of the CPR feedback device in out-of-hospital cardiac arrest improves not only quality, but ROSC, admission rates, and survival with good neurological outcomes. Random controlled trials would be nice. And our limitations was we had lack of pre-intervention compression data. We only had observational data. They were compressing too fast and too shallow. We had a limited geographic area. This is limited to our county within Eastern North Carolina, and minimal AHA changes within the study protocol period. I'd like to recognize Dr. Brobaugh. He had completed one such study similar to this back in 2012, 2013. And with that, any questions?